I didn't even know this group existed until Kurt had spoken to our little team about doing this presentation. And Kurt originally, I think when he came to our little, I suppose, general movements team at John Hunter, he sort of suggested that someone might speak to you guys about the general movements assessment specifically, which we're going to talk about today. But I thought it might be really nice to, and maybe a bit more helpful to consider sort of early CP diagnosis a little bit more broadly than just the general movements assessment. So today I was going to talk through current evidence around assessment tools that we can use to support diagnosis, as well as more prognostic information for kids that we expect will go on to have cerebral palsy, as well as a few bits and pieces around current best practice early intervention. And while I was putting this presentation together, I was thinking also about that it might be good to discuss some of the feedback that we've had from families recently around that early diagnosis process. So we might go through that as well today. So I think Kurt mentioned that I work here at John Hunter as an occupational therapist, but also with the Cerebral Palsy Alliance Research Institute, which is attached to the University of Sydney. And at present, I'm working on a few different research projects, but one of them is looking at the economic feasibility of the general movement screening. So looking at the feasibility of screening all babies that are admitted to a NICU for greater than 48 hours, sort of, I suppose the long-term aim of that research project is really to hopefully have all babies that are born in Australia screened for cerebral palsy, not just babies that we're currently screening that are at really high risk of cerebral palsy already. And one of the other projects that I'm working on at the moment is an early intervention trial that we're co-designing with families who have children with cerebral palsy. And learning from the experience of these families has been, it's been a really good learning experience for me. And as the first step in this research project, we were running focus groups and interviews with families to hear about their early experience of early intervention and the supports that were helpful for their infants in the first 6 months of life. And when we asked families to tell us about this, they all started with their NICU experience and telling us about, diagnosis and their diagnostic experience. And I think for me, it was really enlightening because it really highlighted that, as an OT or someone that's really thinking about very early intervention, that we really can't separate out these early experiences in NICU and these early diagnostic discussions from those early intervention and ongoing supports, because they really shape a family's experience and their trust in the healthcare system. And there's perhaps, hopefully, simple things that we as health professionals working with these infants can consider doing, a little bit differently, slightly differently, that could make a really big difference to the experience of families. Even though your infant being diagnosed with CP and having those early CP discussions is never going to be a positive experience. So as we go through this presentation, I'll talk a little bit more specifically about those research projects in addition to these assessment tools. So early identification and early intervention has come a really long way over the past 20 years. And we know that in cerebral palsy, taking a wait and see approach is no longer best practice. So we know that a family-centered approach is best rather than, health professionals dictating what needs to happen. And in doing so, we really know that we need to listen to the concerns of parents and families. But we also know that families are really key to development and long-term outcomes of infants. So if we support families and really facilitate early attachment and early enjoyment of their infants, this is what can have the greatest benefit for all babies and children that we see. So most of this presentation will be focused on the early diagnosis guidelines that were published by Iona Novak and her colleagues, or a group of international experts, which is probably now due to be updated actually, as there's definitely new evidence around some of these additional tools that we can use. So the recommendations from this paper now form the international clinical guidelines for early detection of high risk of cerebral palsy. So if you're seeing any babies that you suspect might have CP, then definitely it's helpful to refer back to these guidelines. Many of these tools can support us to understand more than just risk of cerebral palsy, but today I'm going to primarily focus on CP because that's what we've been asked to focus on in this presentation. So we know that before 5 months corrected age, the most predictive tools for detecting risk of cerebral palsy are term age MRI, which is about 86 to 89% sensitive, and the Prechtel's general movements assessment, which can actually be more sensitive than MRI. So it's got an overall sensitivity of about 98%. And in situations where an MRI isn't possible and the time frame of general movements has been missed, the Hammersmith Infant Neurological Examination, or the HINE, can be used to predict cerebral palsy with about 90% accuracy. So after 5 months of age, there's specific risk factors that might prompt further investigation for cerebral palsy or other conditions, including not sitting by 9 months of age, and early hand asymmetry or strong early preference for one hand, or the inability to take weight through the feet flat on the floor. So for children over 5 months, a HINE is recommended combined with an MRI, which would of course require sedation by that age. And the DACY and the AIMS are other assessments that can provide additional information about age-appropriate motor skills. The hand assessment of infants.
No worries. I'm sitting in the office. It's very nice of you.
Just going to mute that person. The hand assessment of infants is another assessment that specifically looks at upper limb asymmetry, and it's been validated since the publication of those guidelines. I thought I'd just mention really briefly here a recent publication in Developmental Medicine and Child Neurology about a newborn screening CP calculator that can be used to determine the level of risk. So it's a really new tool. It's not being used routinely, but it might be of interest and something you want to go away and have a little bit more of a look at. So the MRI, I don't claim in any way, shape or form to be an expert on MRI and understanding the prognostic implications of a brain injury identified on MRI. So many of you are probably lucky enough to be much better at this than I would be, or work with neurologists or specialists who have really fantastic skills in this area. So I think the main message with MRI is that not every brain injury is the same, obviously. And based on the brain injury, based on the type and the severity of brain injury, we can really have much more idea of what the infant's function is likely to look like long term. So in addition to that NOVAC early detection guideline, there've been more recent research into what we can tell from an infant's type of brain injury to help with early conversations with families. So this table on the screen, which is actually really fuzzy on my screen, I'm sorry if it is on yours, is from the guideline, and it's really helpful in understanding more about the types of cerebral palsy that are associated with types of brain injury. And there's another 2021 paper by Himmelman and colleagues looking at a cohort of over or just under 4,000 infants who had neonatal MRIs and showed a primary finding that bilateral brain injuries have poorer functional outcomes than unilateral injuries, which probably isn't very surprising when we consider the functional abilities of children and adults with unilateral versus bilateral cerebral palsy. So we know that location of injury may be able to give families more information about specific comorbidities, for example, the likelihood of vision impairment. And this information can actually be really helpful when we're considering early intervention for the child as well as supports for the family. So the Prechtel's General Movements Assessment is a qualitative assessment of the movements in preterm, term and young infants. And from here on, I'll just refer to it as the GMs rather than the General Movements Assessment. So it was developed in Europe by a neurologist by the name of Heinz Prechtel. And it was introduced in the mid-1990s. And it's really, I suppose, a technique used to assess the quality of movements from preterm age to about 5 months post-term age. And currently, it's the most sensitive tool available for identifying babies who are at high risk of cerebral palsy, but it doesn't give us any information about the type or severity of cerebral palsy that baby might be most likely to have. So hence the recommendation to use in infants less than 5 months of age for determining risk of CP based on those guidelines that I mentioned. The General Movements, or GM, is a video-based assessment, and it takes about 3 to 5 minutes of footage of the baby. Like in this picture, you can see the baby awake and on their back and in a calm state. Ideally, they would be undressed just down to their nappy, so you can see all of their joints really easily. So the GM video is really easy to take, but specialised training is required to score the videos. I think Kurt mentioned or was speaking when we first came on here that there is actually some research being undertaken at the moment around artificial intelligence doing the initial screening for the general movements, with the hope, that can save lots of time and effort in scoring these assessments. It's not yet to the point of being as reliable. The AI is not as reliable at scoring as trained assessors are. And there was lots of little groups around the globe working on this separately. But there was a recent summit a couple of months ago where everybody came together. And so hopefully globally, people will now be pooling their resources. And while it's probably still a little while off, the hope is that if we can get that artificial intelligence to the point that it can do a bit more reliable screening, the hope would be that eventually down the track, all babies, not just those at high risk, could be screened for cerebral palsy, just like all babies in Australia are screened for a hearing impairment, for example. So there are two phases of general movements. Writhing movements can give us a really early picture of those infants that we need to monitor more closely, but it's the fidgety movements at 12 to 16 weeks corrected gestational age that are most predictive of CP. So I've got some little videos here. See if they work. So writhing movements, which are ideally taken between about 35 weeks gestation and 4 weeks corrected age, can be classified as normal, poor repertoire, or cramp synchronized. And so the little video that you can see going at the moment is an example of normal writhing movements. So normal writhing general movements are whole body movements that are complex and occur frequently. They, as you can see in this picture, involve the whole body in a really variable sequence of the arms, the legs, the neck, and trunk movements. And they really wax and wane in intensity, force, and speed. And they usually have a gradual beginning and end. So beautiful writhing movements have these lovely rotations that almost swirl from one limb to the next and through the trunk, with an elegance that is really complex and variable. So in high-risk infants, these writhing movements can be monotonous and jerky and really lack variability. Cramp synchronized movements appear almost like this, all muscles turning on at once and then turning off at once, as you can see in the second baby on the right-hand side here. And there's none of these really beautiful rotations that are seen in the baby on the left. So persistent cramp synchronized movements, which can be seen in the second video, are very highly predictive of cerebral palsy, especially if the cramp synchronized movements are getting worse over a trajectory or really persisting over a trajectory of time. But it's this fidgety general movement period between 12 and 16 weeks corrected gestational age that gives us the most valuable insight into risk of cerebral palsy. Let's see if I can run these at the same time. So fidgety general movements, which can be usually seen between 10 and 18 weeks, but between 12 and 16 is the most reliable period of making a call on whether they're there or not, are tiny little calibrations of the neck, trunk, and limbs that are seen as almost this constant background movement. So they should be constantly seen in all directions rather than being two-dimensional and in all joints. So you can see in this baby here, he's got beautiful, almost like this, background current of movement. He's constantly moving. There's these lovely little fidgets happening at all the joints. And you can see, in this baby whose fidgety movements are absent, that the baby's still moving his limbs, he's still moving around, but there's not this beautiful, lovely background fidgety movements happening at all the joints. So it's the absence of these fidgety movements that places children at high risk of cerebral palsy. So when you haven't been trained to look at general movements, it might seem that there's quite a bit of subjectivity in determining the presence or absence of fidgety movements, but there's now been really huge studies across the world confirming the reliability of the general movements assessment. So it's these fidgety movements or the absence thereof that we can be confident places an infant at high risk of cerebral palsy or other adverse neurodevelopmental outcomes. And at this fidgety age, if normal fidgety movements are present, we can be fairly confident to say that the baby is at low risk of cerebral palsy. And of course, we would also always take into consideration the baby's history, any MRI or head ultrasound results, and their clinical presentation. But if the fidgety movements are normal, if the fidgety movements are normal, we can be pretty confident that they won't go on to have cerebral palsy. So if the fidgety movements are not normal, they then classified as either absent or abnormal. So there's in these two categories, for babies who are classified as absent fidgety general movements, they're then classified as high risk of cerebral palsy. So abnormal general movements, which are quite different actually to absent general movements, we know less about from research. So we know that babies who are scored abnormal on their fidgety movements have about a 50% chance of having adverse neurodevelopmental outcomes other than cerebral palsy. So they might go on to have conditions like autism spectrum disorder, ADHD, or developmental coordination disorder. But we also know that half of the children who score in this abnormal fidgety category go on to have quite normal developmental outcomes. And of course, we know that CP is not the only condition that a baby might have, and we really want to be able to identify other infants who might benefit from early intervention. So for those infants who are at high risk of cerebral palsy, we also want to know more than just whether they're at high risk of CP, because this really doesn't give us a lot of information about functionally what that person might look like that infant might look like, and how a family can best support that information in infants. So we really need other tools to give us more sensitive prognostic information, and this is where things like the Hein and the motor optimality score, or the MOS, come in. So the motor optimality score, which has now been revised, so it's called the MOS-R, is an additional assessment that we score using that same 3 to 5 minute general movements video, but we're looking at quite different aspects of the baby's movements and development. So the MOS primarily helps us to do two things. So for infants that are at high risk of cerebral palsy, it gives us more prognostic information about the typography and the severity of cerebral palsy that infant is likely to have. And for infants who are not at high risk of cerebral palsy, so who have had normal fidgety movements, but whom we might be worried about, it gives us actually a more quantifiable way of identifying those infants who might benefit from early intervention. So the MOS was originally published in the General Movements Manual in 2004, and then it was adapted to use in various studies. And the most recent version was published in 2019, the MOS-R, and it's also produced by the European General Movements Group. So it can be used by certified general movements assessors, and it's taught in the Advanced General Movements course. So 4 of our NICU team are trained to use this tool. So this slide shows summary scores for each section. So the MOS looks at things like, is the baby bringing their hands to midline? Are they kicking? Do they have a range of different movement patterns? Are they able to hold their head in midline? Do they have varied finger postures, for example? So this is a pretty new tool in the scheme of research and tools. And even though it's been around for about 15 years, we know that the research to practice lag is generally about sort of 7 to 15 years. So it's really just been, starting to be used more regularly in clinical practice. And over the last 2 years or so, there's been a lot more research done on this tool. So what do we know about the MOS-R and what it can tell us? So in a CP cohort of just under 500 children, a large study showed that looked at the MOS in relation to GMFCS levels, so gross motor function classification level, and found that the MOS was associated with later gross motor skills. So a lower MOS score was associated with lower GMFCS level or poorer gross motor skills. So in that way, it could be a useful tool to aid prognostic information provided to families, such as the likelihood that the infant will go on to walk or not. A MOS of 8 or below was strongly associated with children who would go on to not walk, so GMFCS 4s and 5s, and a MOS above 14 with fidgety movements absent was strongly associated with children who would go on to be higher functioning children with cerebral palsy, so GMFCS 1s and 2s that would generally be able to ambulate fairly independently. So some of the early moss research in a range of different cohorts can also tell us that certain early movement patterns might be predictive of later outcomes. So abnormal movement patterns associated with CP were abnormal mouth movements, abnormal foot-to-foot contact at that 12 weeks of age, abnormal arching, as well as abnormal visual exploration. And there were also certain postural patterns that were significant. So there were 7 different studies reporting that a lack of variability of finger postures was a significantly related to prediction of later outcomes, and probably particularly in regards to learning and cognition. So, these, 7 studies, a small number of studies, but it's kind of, early studies are suggesting that, the amount of finger postures or individual finger movement at that age could be associated with later cognition or learning skills. In regard to movement character on the moss, although a monotonous and jerky movement character was more prevalent in high-risk infants, which are the majority of the infants that we're screening and looking at, the association with later outcomes wasn't clearly established. And this is partly because a proportion of any control infants in these studies demonstrated abnormal movement character as well. Okay. So I've just got a little example video of what we might look at in this moss. So this is an infant who shows some really lovely signs, and the things that we might look at with that moss or that motor optimality score are things like, is the baby at this 12-week age bringing their hands to their midline? This baby's looking around beautifully. It's able to maintain their head in midline. It's bringing its feet together, lifting its legs up, doing lovely things at this age. So this is really different. This MOSAR is looking at really different skills and abilities to just those fidgety movements that we're looking at. And probably it's looking at more typical, postural and movement patterns that we would look at than, thinking with a general movements lens. So the HINE is the other main assessment tool recommended for the early diagnosis of cerebral palsy in that international guideline. And, I think many people think this is, a standard neurological examination, and it is, but the difference probably is that it's standardized. So its scores can really give us, quite valuable predictive information. So there was a publication in 2017 that pulled together the predictive values for cerebral palsy for a range of different neurological assessments. And it found that many of the neurological assessments were good at discriminating between abnormal and neurological functioning at that point in time, rather than necessarily being able to predict the outcome for an infant. So the HINE was found to be the most reliable neurological examination to give us more reliable predictive information at this early stage. So the HINE, out of all these different neurological examination tools that are out there, was found to have the highest sensitivity and specificity for the early detection of cerebral palsy. So it was about 90% when it was carried out at either 3 months or 12 months of age. So the HINE was developed in London in 1999. It's a pretty new tool. And because it's a standardized assessment, we can actually interpret the score that it gives us to provide current as well as predictive information. And it can be used from 2 months of age, 24 months of age, but it is actually only validated for term and preterm children from 3 months to 18 months of age. So in terms of the predictive validity, sort of from that 3 month to 18 month mark, is optimal. And it's also probably important to state here that the predictive validity is more reliable from 5 months of age. So when we're using it at 3 or 4 months of age, we can be less confident in its predictive value than from 5 months onwards. So you don't need to be formally trained or certified to use the HINE in clinical practice. And there's actually self-study videos and a lot of HINE resources available online. So I'll put a little link here. And I think there's, a full, really detailed online course for the HINE now that can be accessed. I think it is an annual fee of about £90 or something to be able to access this online. And I haven't actually done the online workshop. I've only done face-to-face workshops, but it's supposed to be a really good online workshop that takes you through everything, including how to interpret the scores that you receive. So in-person training is also available, depending on where you live. So the Hine looks at a few different areas of functioning. So it looks at cranial nerve function, looks at the postures of the baby, the quality and the quantity of movements. It looks at the baby's muscle tone, as well as reflexes and reactions. And it gives you an overall or a global optimality score, which can be between 0 and 78. And basically, the lower the score, the more concerning the result. And what we classify, or what the research classifies as optimal scores, are scores that were found in 90% of typically developing or the healthy population. So the original paper from 1999 described how optimality score was developed and validated, and it found that at 9 to 12 months of age, a score of 73 or above was regarded as optimal, and at 18 months of age, a score of 74 or above was considered optimal. And since that time, in order to establish whether the scoring system could also be used in younger infants, and the authors have assessed healthy term infants between 3 and 8 months of age, and it's also been used a lot in premature infant populations. And the results of all this different research have really suggested that the criteria for optimality developed for infants at 12 and 18 months can apply from 6 months onwards, while for younger infants, the scores are lower because of any immature tone and saving reactions in that age group. So the Hine specifically in relation to cerebral palsy is a little bit different to optimality. This critical review looked at studies that have used the Hine in infants that are at high risk of cerebral palsy. So it included studies to look at the various cut scores for prediction of cerebral palsy. So infant groups were those who were at risk of cerebral palsy, including infants who had had, HIE or cystic PVL or neonatal encephalopathy. And the meta-analyses of all of these found that at 3 months, a Hine below 57 and at 12 months, a Hine score below 66 was able to predict cerebral palsy with a really high accuracy, so over 90% sensitivity and specificity. So additionally, a Hine score below 40 was found in infants who went on to have quite severe cerebral palsy. But I think it's also really important to note here that a low Hine score, even those below these cut scores, doesn't obviously always mean cerebral palsy. There can be other reasons why an infant might be scoring low. However, global suboptimal scores, when they're not associated with CP, have also been to be associated with other minor neurological signs or low psychomotor development later in life. So this one was a retrospective study, and the authors looked at a population with CP at 2 years of age, including their 2-year-old GMFCS levels. And in this cohort, they had a Hine completed at 3, 6, 9, and 12 months. And this study found that in regards to the severity of cerebral palsy, again, if they have had a Hine score below 40, this was strongly associated with children who would be GMFCS 4s or 5s, so that they would have really poor gross motor skills and wouldn't be able to walk independently. And for those kids that had a Hine score between 40 and 60, that was strongly associated with kids who were GMFCS level 1 to 2, so kids with cerebral palsy that would be able to walk independently. Importantly, the Hine can predict more than just cerebral palsy because we want to think more broadly than just CP. So the Hine wasn't developed as a tool for the prediction of cerebral palsy or the diagnosis of cerebral palsy. It's just that the majority of research with the Hine has been done in the CP population. So, that has been used in other populations as well. And I think importantly, in looking at cognitive outcomes. So early cognitive interventions are something that we don't do particularly well. But if we're able to provide opportunities for learning, primarily through play, then we can provide lots of really, early opportunities to hopefully help the long-term development of those infants. And so cognition is something that we want to think about early, that we haven't been very good at thinking about. And the Hine is a tool that can help us to understand those infants who might be at risk of cognitive delays later in life. So if an infant has a poor score in their hind, but nothing else suggests that they might have cerebral palsy, they don't have any history of brain injury, they're not presenting with a primary motor difficulties or impairments, then cognitive intervention early on might be really helpful for that infant. So we wouldn't expect to see a hand preference in the first 12 months of life, and upper limb asymmetry is a red flag for further assessment. So when there is a risk of an upper limb asymmetry due to the history, such as an IVH, or we observe a hand preference, we know that there's specific interventions that can be effective. And more effective the earlier that we actually carry out these interventions. And it's probably this cohort, so the really mild hemis that will go on to have CP, that really respond best to very early intervention, which can, potentially have really positive impact on their long-term function and outcomes. So the hand assessment of infants, or the HI, is a tool that tells us how well the child uses each of their hands separately, as well as their hands together. So whilst other assessments that we've talked about today are examinations of movements and posture, the HI is really about, functionally looking at what the infant is doing during their play and how they're using their hands actively and naturally during play. So this tool can add quite important prognostic information, but most importantly, guide interventions. So specifically in regard to whether we might use soft strategies with an infant, such as unilateral stimulation, or whether more intensive upper limb interventions, such as constraint or bimanual therapy, might be helpful for that infant. So that's sort of the majority of what I was going to talk about in terms of assessment tools. And I thought I'd also mention here, what we currently know is best practice in terms of early intervention for infants, once they leave our units and go off into the big wide world or head home with their families. So life looks really, really different, for every child and family. And I think it's really important to keep this in mind when we're using assessment tools and having discussions, and particularly when we're considering really early interventions. And so I'll just talk briefly about what we know is best practice for early supports and early intervention. And I know probably the majority of you guys here are doctors, but I think it's also always really great for doctors to be thinking ahead to what allied health supports these infants might be getting. So evidence tells us that there's some really key principles that are seen as best practice when we're providing early intervention to families. Once they're medically well and they've headed home, but even, we can be really considering and starting to think about these things when they're in our units. And these principles are really in keeping with the current World Health Organization priority areas and the International Classification of Disability, Health and Functioning, or the ICF. And so we know that early intervention and supports should definitely be family-centred. So they should be adapted to each baby and that baby's families and what is most important to that family at that point in time. They should also be really specific and goal focused. So, we should be really clear about, what's most important to that family and what we're trying to achieve with that family. And thinking about, what skills would the family really love to see their child doing next. And this is even something that we can really be thinking about, with our inpatients, is what is the thing that that family would love to be doing with their infant next. So we know that best practice early intervention is holistic. So it should consider the whole child and the family rather than just focusing on an arm or a head or a leg or nutrition, without thinking about what really fits in with everything else that's happening at that point in time for the child and the family. And we know that from a therapy perspective, early intervention should be active. So this really alludes to our change in thinking over the past 20 years around how we best facilitate movements, I suppose, in particular, to facilitate neuroplastic change. And we know that the more a child can be actively doing them themselves and actively involved, rather than us having our hands on them and doing it for them, the better the improvements are likely to be. And we know that best practice early intervention is provided as a team. So really with the child or the infant and the family at the centre and as part of that team. And we know that it's really important when a child and a family have multiple and lots of professionals involved, that everyone really works together to decrease the stress and the burden on families. And there's really good evidence to support this. We also know that evidence-based early intervention is not prescriptive. So no longer in healthcare is it, best practice for us to sort of be the all-knowing clinician who tells families what's wrong and what they should be doing. And our role is really to share our knowledge and our skills with families to really empower them and enable them to make choices about what they see as best for their child. So sometimes this is really hard because it's not always, what we see is most important for the child. But research really tells us that if a family trusts us and feels that we have listened to them, that they're more likely to follow through on any recommendations or suggestions that we might make. And research also tells us that if we come up with a plan together with families, that this, that they're more likely to follow through on things rather than, so if we're coming up with plans that are really realistic to suit them and that are most important to them, it's more likely that this plan's actually going to be successful. So evidence-based early intervention isn't judgmental. It's really important for us to adapt our ideas to fit into the lives of different families we work with. And we also want to make sure that it's not just impairment focused. So there's always, we definitely need to think about underlying impairments, but it's really important for us to be thinking about any impairments within the context of really what are we functionally trying to achieve here, and ensure that our interventions support that in the long term. Okie doke. I thought I'd just share, I think I mentioned at the start that we've been, working with some families doing focus groups and co-designing some early intervention research with families. And I thought I'd just share the experience of some of the families that were involved in that process, as well as some of the suggestions that they've had for how we as health professionals involved in their really early care might be able to support them better when we're having some early discussions around their infant being at risk of cerebral palsy. So I thought I'd share a couple of quotes from the mums who had told us their story. So I knew she had had a stroke, but I didn't know that could mean she would have cerebral palsy. I felt so stupid. I wish they had used those words so I knew. She started talking at me about things, and after that, then no one came back. There was never anyone that came back to say, okay, is maybe now a bit of a better time to have that discussion. The hospital decided when I should be ready for that conversation. I was not given space. Diagnosis discussions often are driven by the healthcare professional that's having that conversation. We were told there was nothing that we could do to help, and we found out later that that was wrong. So these families also, whilst acknowledging that this discussion, these early discussions around the possibility of cerebral palsy are never, ever going to be a really positive experience, and that they know and acknowledge there's no definitive answers, but they also thought that they could have some simple suggestions for us as health professionals working with other families who have infants in this situation, how these conversations perhaps could happen a little bit better. So some things for us to consider. And they suggested we could be flexible with how and when we give them information. Tell us we'll be having a hard conversation and ask us when we'd like to have it and who we'd like to be there. They also suggested offer the information more than once. As families, you don't remember information when you're in fight or flight mode. Share what you know about our baby with us, even if it's hard, we need to know. So a lot of the families talked about how they felt like, while there was lots of health professionals with the best of intentions, making decisions about what information to provide them and what not to, they felt like it was really important for them to be given most of the information so they could make decisions. They also said, use words like cerebral palsy. We don't know a brain injury or a stroke means our baby might have cerebral palsy. And tell us what we can do to help. We really want to help. So I suppose a few take-home messages. we can definitely identify infants early who would benefit from early intervention at a young age. And specifically in regards to cerebral palsy, taking a wait and see approach really isn't classified as best practice anymore. Neonatal MRI can definitely support prognosis. And 3 to 6 months is a really critical period for some of those more hands-on or therapeutic assessments that can be completed. So it's really important if there's concerns identified at that point in time, even if they're concerns from the parents and the families, that referrals to specialist services are initiated. The general movements assessment is the most sensitive tool for predicting cerebral palsy, and it's a really low cost and accessible tool because families can take the video themselves at home, and the video can then be shared with trained clinicians. We know that early intervention makes a big difference, and also that supporting the needs of each individual infant and their family rather than just generic suggestions or prescriptive exercises is definitely best practice. Thanks so much.
Oh, thanks, Michelle. Well, it's wonderful to see how far this field has come, you know, from remembering my training with Ari Boss in the sort of late 90s to now. And, you know, you talked us how teams and researchers, including yourself, have matched brain development to movement patterns. And it was very broad in the beginning, but you made it smaller, you classified it, you did a lot of research to test that classification and the scoring, and you brought us information about some of these tests, general movements, Moss, Hein, and various other tools there. You showed all the research which is there, and it is, you know, overwhelming, and we just need to refine it now. And then you brought us to that last bit, which was really eye-opening, I guess, you know, taking parents to early intervention. It's a word, isn't it? But what that means is very different from each individual healthcare system.